this baby taught us a lot of things. So I think Anjali will take over from here, and we will conclude after she presents. Okay, carry on, Anjali.
Yeah. Good evening, all. Today's clinical club is on herniation of brain in neonates. I know it may sound a little weird to hear herniation in neonates, but that is what we are going to deal about. That though it is very rare, it is not very uncommon. Thank you for this opportunity. So going ahead, I have a small poll. So I would like you to kind of answer these questions. Can you see the question 1 and question 2? It is an image-based question. Someone in the audience can just say, like, whether they can hear, or in the chat they can mention.
Yeah,
if you can see the poll, can you see? Yeah.
No, please relaunch the poll.
Yeah, okay. Yeah, can you see the poll now? So there are two images. Question 1 is, what is the circled thing in the image? Is a CT scan, whereas the second one is a type of herniation. So you can give me your answers through polls. Okay. I'll end the poll and I'll share the results.
There is an option for poll in the final. Okay.
Yeah, so as you can see, the first one, for the first question, most of you have answered rightly that yes, it is basal cistern. And this is seen on CT scan, and it is an important landmark that we can actually see while evaluating for any edema, herniation, hydrocephalus. Similarly, the second question was regarding which is the type of this herniation. You're absolutely right. It is under the falx cerebri, where the cingulate gyrus actually herniates, and this is called as subfalcine herniation. 50% of you have answered it right. Whereas the last question was, which is an effective agent to treat raised ICP in neonates? 63% of you have answered it as hypertonic saline. And yeah, we will see as I go through the slides whether the answer is right or wrong. So let me just go through my presentation now. So the objectives of today's clinical club will be to look at a case scenario, then look at physiology of basic brain herniation, the myth in neonates and why is it a myth, and case series that have been seen so far, clinical signs and symptoms of herniation of brain, and radiological findings, and ultimately the management. So coming to this baby of ABC, which was a term 39-weeker boy baby delivered by normal vaginal delivery on 9th of October to a primary mother with no significant antenatal history. Mother was a known case of seizure disorder and was on Levopill. Apart from that, all the antenatal scans were normal and they had come for safe confinement. This term baby boy had difficult extraction. And during intrapartum monitoring, it was all suggestive of fetal tachycardia. But as she progressed, the baby delivered through normal vaginal delivery. Post-delivery, baby was limp, did not cry immediately after birth, but the heart rate always was more than 100 per minute, but there were no spontaneous efforts. Baby required positive pressure ventilation and was later intubated in view of poor respiratory efforts, or in fact no respiratory efforts in the delivery room, with an FiO2 of 40%, PIP of 18 by and TEEP of 5. Apgar at 1 minute was 2 and at 5 minutes was just 3 by 10. And baby was shifted to NICU for further management. At NICU, baby was nursed under warmer care, was connected to SIMV mode of ventilation with minimal parameters. The main reason for ventilation was poor respiratory efforts, and baby also had poor tone and was hypotonic. Baby was deferred therapeutic hypothermia as the baby did not meet the physiological criteria in the form of cord ABG was 7.09 and base excess was just -11. Baby was started on IV fluids and was monitored for seizures, but there were no clinical seizures whatsoever. On examination, vitals were temperature was normal, 36.8 degrees centigrade. Heart rate was 170 beats per minute. Respiratory rate was bradypnea or almost nil respiratory efforts, less than 20 per minute. CFT was prolonged. GRBS was normal. SpO2 was around 97% on SIMV, as you can see, with minimal parameters of 25% FiO2 and 12 of PIP and 5 of P. On general physical examination, baby had extended posture. Baby had a huge subgaleal bleed in the form of boggy swelling that we could palpate. And baby had no spontaneous movements. And on general physical examination, baby did not have any dysmorphism. On systemic examination, baby was in severe stupor. Pupils were mid-dilated but reactive to light. Baby was in profound hypotonia. DTRs were not elicitable, and neonatal reflexes were absent. Respiratory system examination revealed reduced efforts, but bilateral air entry was normal and clear, and as the CVS and per-abdomen examination was normal. So at this point of time, the differential diagnosis that were considered was baby might be having HIE, since there was a difficult extraction and the baby had huge subgaleal bleed. We thought it might be secondary to intracranial bleed too. And the third one was, it was odd that the baby always had tachycardia even during the intrapartum monitoring and also after delivery. So maybe intractable seizures or cerebral malformations were the third differential that we had actually kept. Immediately on day 1, baby, because of subgaleal bleed, had anemia, so received PRBC transfusion. Shock was adequately managed with inotropes using dopamine, dobutamine, and adrenaline, depending upon the echo. And baby was continued on ventilator on minimal parameters. NSG focus was done, and it was suggestive of diffuse cerebral edema, slit-like ventricles, as you can see over here. Can see where you cannot actually demarcate the ventricles, and all are hyperechoic lesions that you can see is all edema around. Baby's condition was similar even on day 2 and 4. There was no further improvement. Baby clinically did not have any seizures, but when we connected the AEG, it revealed burst suppression pattern and absent sleep wave pattern. Bradypnea persisted, and anterior frontal lobe started becoming more tense and it was bulging. Pupils now became fixed and dilated. So then we went ahead with MRI brain. When we did MRI brain, these were the features that it revealed. So this is T1 weighted axial MRI imaging, where you can see a lot of hyperintense lesion which can be seen around. This is actually the subgaleal bleed seen outside the calvaria. Then in the T2 weighted axial MRI, we could see hyperintense lesions around the cortical areas, predominantly around the cortical veins. And this was predominantly reported as edema, diffuse edema around, and the sulci and gyral pattern was all effaced. So there was edema which was actually revealed in the MRI. Next, subsequently, this image that you can see over here, hope you can see the video. This image is called as a SWAN sequence, which is also called as susceptibility weighted imaging, where depending upon the various susceptibility of the hemoglobin, this will actually come into picture. So this is predominantly used to recognize any bleed or any thrombosis. So this revealed, as you can see, it's the same image with the contrast adjustment. This is called as, if you can see, just a second. Yeah. So this, what you can see over here is called the blooming effect. And this was seen in both the straight sinus as well as the deep medullary sinuses in bilateral hemispheres, which was suggestive of cortical vein thrombosis. So this is the same SWAN images showing deep medullary veins involvement and deep medullary vein thrombosis. The next imaging, which you can see over here, is a T1 weighted sagittal image, which actually shows that there is tonsillar herniation. As you can see, this is the tonsil and it is below the sternum. This is actually descended down. So this is actually suggestive of tonsillar herniation. At this point of time, parents were actually explained about the poor prognosis. Though the baby was started on medical management for herniation or raised ICP in the form of continuous 3% NaCl infusion, but in view of poor prognosis, parents decided to take baby home. And they went discharge again, medical advice, and the baby succumbed immediately. So now coming to about the case, about the pathophysiology. We all know about the famous pathophysiology, that is Monroe-Kelly doctrine. What actually it mentioned was the cranial cavity or the cranial vault is very rigid and it is filled with non-compressible contents like three main important contents, that is your CSF, brain parenchyma, and blood. And any increase in any one of these components will increase or raise the intracranial tension, and subsequently to accommodate that, the other tensions or the other areas will actually succumb to it. So when you see the graphical representation of the same, there is a normal amount of percentage that is actually divided for each of the component, for brain, the arterial blood, the venous blood, and the CSF. Now, whenever there is a mass or compression or anything when the venous return is hampered or when there is a bleed, what happens is the brain parenchyma gets compressed because of the reduced venous return. And at the same time, CSF also starts getting gets affected depending upon what is actually happening. So the compensatory mechanisms that actually come into picture is, one, they can either reduce the CSF by increasing the CSF absorption or by reducing the CSF production. Or the second thing the brain, which the overall body can do, is decreasing the cerebral blood volume. How can they do that? Is increasing the venous rhythm. And the third thing is increasing the cranial capacity. That can happen when there is sutural splaying or sutures start expanding pathologically. So whenever this happens in an adult where already the sutures are closed, then that leads to decompensation within minutes or seconds. Whereas the general myth in neonates is this doesn't happen because already the sutures are separated. So this should be able to accommodate. The other mechanism that happens, that is the cerebral hemoregulation in case of raised ICP, is overall the brain wants to maintain the cerebral perfusion pressure. How does that happen is, any mean arterial pressure minus the intracranial pressure is actually the cerebral perfusion pressure. So whenever the MAP increases, there will be a vasoconstriction, so that it is a kind of autoregulatory mechanism that is present in the brain that will help in maintaining the cerebral perfusion pressure. Whenever the map falls in the other aspect, the CPP also tries to vasodilate so that adequate blood flow is present, and that will also help in maintaining the cerebral perfusion pressure. But whenever there is a decompensation like this, as you see, then this cerebral perfusion pressure gets affected after a narrow range of autoregulation when it actually fails. This autoregulation mechanism is very narrow in case of preterms compared to terms. Now, what happens when this herniation, the compensatory mechanisms actually fail? So, as you can see, this is a cranial vault, and these are the tentorium cerebelli and the tentorial notch, which is actually for the medulla oblongata and other things to actually go. And there are few spaces which are actually given for the cranial nerves to pass. And this tentorium cerebelli actually separates the infratentorial region, that is the cerebellum, from the cortical regions. And this falx cerebri, which is present in between, separates the two cerebral hemispheres. Now, what happens subsequently is when there is any whenever there is displacement, or whenever this doctrine actually fails, or one component gains priority over the others, then these are the areas where it is a little lax, and the brain tissue tends to kind of herniate. So the main four types of herniation that can be seen are: one is subfalcine herniation, that is mainly the cingulate gyrus which actually herniates. The second one is the central herniation, where depending upon the degree of the cerebral edema or degree of the insult, the central system, that is predominantly your pons, midbrain, can herniate, and through the central incisura. And whereas this region that you can see is transtentorial herniation, which is through this region, which is uncal herniation. Temporal uncus region of temporal lobe can actually herniate. And the last one is the tonsillar herniation from the foramen magnum. So as I already said, these are the four different types of herniation. So next, what happens is, why does this happen in neonates? So here you can see a mermaid. So it is very similar to that. Neonates' brain does not herniate. This is a myth. Why? Because skull bones are still very compliant. There are open fontanelles, and there are empty spaces which are available around the brain, which are actually which is actually necessary for the rapid brain growth. So even if there is a raised intracranial tension, most of the time this actually should be able to accommodate, because all these are very lax. But the truth is not so. As you can see, that was not a mermaid. This was actually a girl being eaten by a large fish. So similarly, neonatal brain, though rare, neonatal brain herniation, though rare, it can herniate. So there are few case series that I actually reviewed. There are so far 9 cases which have actually been published as case reports. And most common causes are actually intracranial tumors, which has mostly caused tonsillar herniation. Infections are another predominant cause, which has caused uncal herniation secondary to bacterial meningitis in one of the cases. HIE is another predominant causes, where it has resulted in tonsillar herniation in 2 of the cases. And antenatal infarction has caused tonsillar herniation in one of the case. And sometimes even vacuum extraction, which has led to dural tear, has led to parietal lobe herniation, which is one of the cases reported in 2007. So it looks very less, isn't it? So what we ultimately felt is, they are mostly undiagnosed or underreported because of the rapidity of progression and succumbing of the neonates very quickly. So mostly they may be either undiagnosed or underreported. So what are all the clinical signs, or when should we actually suspect them? So whenever there is a change in level of consciousness, all babies who present to us with neonatal encephalopathy should be clinically monitored as frequently as possible, at least every 4-hourly, for the neurological examination, wherein we have to look in for the change in the level of consciousness, whereas that is mainly from slight stupor to increasing level of stupor. Second one is the differential tone or reflexes or power. So differential tone is something which is very important that can be picked up by neurological examination. The next one is altered breathing pattern, hypoventilation, apnea. Initially hyperventilating and later on going into hyperventilation or apnea is another important clinical clue. Next can be bradycardia. This is one of the things that can be seen as a part of the Cushing reflex. Next one, it can be raised mean arterial pressure. With the arterial pressures can be very high. And pupils, though they are small, they can be really giving a way big of variable number of information, like asymmetry, pupil dilation, or anisocoria, non-reactive pupils, especially over a sequence of time, is actually a very important set of clinical signs that needs to be picked up. So when you come to overall diagnosing brain herniation or raised intracranial tension, there should be adequate clinical information because they compose of all of neurological syndromes and should have patient history and all the risk factors. When you do the imaging, you should actually already know the anatomic landmarks that are actually important, like falx cerebri, tentorium, foramen magnum, septum pellucidum. The next thing that we want to look in the imaging modality, because that is one of the important ones, is the direction of the mass effect. That is to analyze the location of the pathology and force or the side in which it is actually getting herniated. And with what is the displaced structure? This can also be predicted with the clinical information or based on the anatomical parameters seen on the MRI or the CT scan. Then the indirect signs can be the hydrocephalus, the ventricular system, or the brainstem, the rotation of the system. This can also give us indirect clues. And the herniation related complications like stroke, infarction, or hemorrhages, hydrocephalus are the next set of information that can be gained by during a imaging. So the immediate imaging modality of choice is CT scan. Though in neonates, we are like worried because of the exposure to the harmful radiations. But in such critical situation, when you actually do the risk benefit ratio, I think CT scan is a quick imaging modality and it will give us important information. So as you can see over here, the one is actually the basal system, which I had asked in the poll, that gets effaced or obliterated. So that basal system cannot be seen at all. The second one is the enlarged lateral ventricle, which might be because of the edema or because of the mass effect. And the third one is enlarging third ventricle, again because of the mass effect. And overall effaced sulci and gyrae, which we could see in our baby too, because of the cerebral edema. So for acute cases, as I said, CT scan is important or very valuable. And repeating the scan after 24 hours definitely adds on to the effectiveness. But the main disadvantages of CT scan is the overall sensitivity is just 75%. Sometimes even this, without this basal system getting obliterated or without this hydrocephalus or enlargement, there can be raised ICP2, and which is very difficult to kind of predict. So the sensitivity overall of CT scan is poor, and it cannot detect the etiology. The overall the bleed may be very small and other things, and the soft tissues are not very nicely visualized. So overall, we cannot actually say what is the cause for the herniation or raised ICP. So other imaging modality of choice is ultrasound, wherein we can see edema, bleed, and hydrocephalus. And resistive index monitoring of anterior cerebral artery is definitely one of the good surrogate markers for raising ICP. The normal RI are between 0.5 to 0.7. Any raise in RI or delta RI of more than 30% is suggestive of increasing ICP. NIRS is another near infrared spectroscopy is another important modality which is coming up, but it is still evolving, where we can actually see the regional oxygen saturation. But the studies on that for correlating with raised ICP is still evolving, and it has all been done in the pediatric population, and in neonates still the normal values are yet to come out. The last imaging modality of choice is MRI, and which actually helps in detecting both the etiology, the type of herniation or cause, and also the for prognostication. But the best choice to actually say or interpret the raised ICP or the ICP monitoring is the direct ICP monitoring by introducing the electrode, wherein which can actually, with the catheter, you can directly help in monitoring. But the problem with the catheter is, again, risk of infection, meningitis, and in neonates, it is very difficult. So these are all the basic anatomical areas that needs to be seen in case of a imaging. As you can see over here, this is falx cerebri, and this is cingulate gyrus, which you can see over here. This is corpus callosum, and this is the tentorium cerebelli, which you can see here. And this is the tentorium incisura. So these are all some important landmarks that we would like to look at when we are looking at an imaging, which can be the CT scan or MRI. Then, as you can see over here, this is cingulate gyrus, which is above the corpus callosum. And these are all the cisterns that I actually mentioned. These are all a component of basal cisterns. And these are obliteration of this or increasing this of content of this can also should be assessed when we are actually looking at an image of raised ICP. So coming to various types of herniation, the first one is the subfalcine herniation, also called as cingulate herniation. In pediatric population, this is most common type of herniation, and this in this what happens is the cingulate gyrus actually herniates from under the falx cerebri. The clinical scenario would be altered consciousness, contralateral limb weakness. As you can see, this is the area where actually your limb expression or the cortical comes. Corticospinal tract comes. So the contralateral limb weakness can be there, and anterior cerebral artery is also at this area. So if at all, if there is this anterior cerebral artery gets compressed, then that can lead to paraparesis. Next, coming to the imaging, what will you actually see is mostly in the anterior falx that you can see, as you see over here, there will be a midline shift of falx. The falx itself, this is the falx that itself is shifted from the midline. Now, depending upon how much it has shifted, we can actually prognosticate. Less than 5 millimeter shift is actually considered good prognosis because with the treatment, it can reverse back. More than 15 millimeter is considered to be poor prognostic factor. And one more thing that can be seen is asymmetric dilation of ventricles. Coming to the next one, that is the uncal herniation. As you can see over here, the temporal lobe has uncus and that gets herniated under the lingual tentorial incisura. So what happens here is clinically, they will mainly present with ipsilateral pupillary dilation because there is uncal herniation. That corresponding third nerve gets paralyzed. So ipsilateral pupillary nerve, the ipsilateral third cranial nerve, oculomotor nerve, can get paralyzed and lead to pupillary dilation. And contralateral, because of the compression of the corticospinal tracts, that can lead to midbrain compression, leading to contralateral hemiparesis. But and one more thing which is important is there will be worsening consciousness because of the compression of the ascending arousal tract systems in the midbrain. There is sometimes there is a phenomenon called as Kernohan's notch, where what happens is this uncal herniation will become so much so prominent that it will displace and cause compression of the contralateral system, leading to contralateral pupillary dilation and ipsilateral hemiparesis. So this is called as Kernohan's notch phenomenon. Next important thing is the thing that can be seen is widening of the perimesencephalic cistern, effacement of the cisterns, as you can see over here, and the brainstem itself can get rotated. Like they will not be having the normal orientation and they can get rotated. So these are all the features of your uncal herniation. The next important one is the tonsillar herniation, which was seen in our case too. The anatomy is mainly the cerebellar tonsils. Pons can get herniated through the foramen magnum. It will lead to compression of the lower brain system and also the upper cervical spinal cord, which will lead to mainly lead to compression of the vital areas that leads to cardiac and respiratory dysfunction, autonomic instability, loss of consciousness, and lower cranial nerve dysfunction. On imaging, one important landmark is this McRae line. As you can see, this is the line. It is an imaginary line which is drawn on the imaging, which is extending from the basion to the office thorn. So this, if after drawing that line perpendicular to that, you see how much the tonsillar area has actually descended down. So if this is more than 5 millimeter below this McRae line, then it is considered as herniation. This will further cause compression of the brainstem and also causes hemorrhages, small punctal hemorrhages called as Durett's hemorrhages over this area. And because the fourth ventricle gets obliterated, this can lead to hydrocephalus. So here in our case, this is our baby's image. As you can see, this is the McRae's line that we have drawn. And the descent is almost 0.56, that is 5.6 millimeter, which is below the tonsillar herniation, which is suggestive of tonsillar hernia. Now coming to the central herniation, as I said, this is through the foramen this is the central, this one incisura. This will lead to mainly the thalamus and the hypothalamus, and later stages, pons, medulla, everything can herniate through the tentorium cerebelli. The clinically, what they actually present is with pupils. Initially, they will be pinpoint because of the pons which is getting compressed, and later stages they will become irregular, mid-dilated, and fixed depending upon the level of herniation or the anatomical structure that is getting herniated. Then one more important thing is lowering of consciousness or increasing stupor. The posturing can range from decorticate to decerebrate and later lead to profound hypotonia, depending upon which are all the structures that are getting herniated. Hyperventilation to later sigh breaths and apneas are seen, and absent Dolci response. On imaging, what we can see is this is the perimesencephalic cistern, which is getting obliterated. There is rotation of the mesencephalon, ventricular dilation, and left displacement of the quadrigeminal plate. This is the quadrigeminal plate which is displaced to the left side. So these are all the findings that you can actually see. Now coming to these are the imaging modalities. So overall, these images have to be interpreted with the clinical correlation, and just interpreting the images will not be helpful. Now coming to the management, the general management for involves mainly taking care of the temperature, because any hypothermia or hypothermia can lead to further deterioration of the consciousness and further cause edema and worsening of the herniation or cranial tension. Airway needs to elective intubation is important with good analgesia, and we should avoid ketamine. Head should be always put in the midline. This is to avoid compression over the jugular vein. And also the head and elevation should be between 15 to 30 degrees. This is to reduce the ICP. This was studied in one of the studies in 1992, where they felt that between 15 to 30 degrees of elevation actually gives the optimal amount of cerebral perfusion pressure and also reduces the ICP. But anything beyond 30 degrees have also been tried in few of the studies. And now recently in pediatric brain salvageable articles suggest, especially for this raised ICP measures, they have said that it has to be optimized, and depending upon the monitoring of the ICP, we can adjust it to various amount of elevation. Next, hypoglycemia or hyperglycemia should be avoided. And hemoglobin, because overall it all depends upon the oxygen delivery, should be maintained about 10 gram per deciliter. And adequate analgesia or sedation should be ensured. And any seizures which can be detected by AEG should be treated and managed. Coming to ventilation, the norm is we should ensure normoxemia, neither hyperoxia nor hypoxia, that is between 50 to 60 mmHg. And any hypercarbia or hypocarbia is not preferred. Though previously they said that hyperventilation is one of the modalities, but whenever this PCO2 goes it exceeds, it will lead to vasodilation, and that can further cause perfusion issues. So that is the reason why hypertension or hyperventilation should be avoided. Similarly, hypocarbia, that is less than 30 mmHg, should also be avoided. Any increased PIP and PEEP should also be not legible. And protected suction, because even one time suction can also lead to sudden increase in the ICP, and that can cause worsening of the clinical condition. So it should be protected. Coming to circulation part, we should ensure that should be a good access, and intra-arterial BP monitoring is preferable, and we should avoid hypovolemia. There is no need for fluid restriction. The overall fluid monitoring should depend upon the overall volume status of the child. Now, with the help of focus and also the continuous clinical monitoring and urine output measurement, we should, and also weight monitoring, we should be able to regulate the volume accordingly and not do unnecessary fluid restriction. We should ensure that normal blood pressures are maintained, and the target cerebral perfusion pressure is between 50 to 60 mmHg. Isotonic fluid is definitely preferred over the hypotonic fluid, and inotropes should be given as and when required. Now, coming to the specific measures, actually there are no standard guidelines for how a neonatal raised ICP should be monitored or managed. Even in pediatric age group, there are lots of studies which are coming up, and it is not like streamlined. Main mechanism of these specific measures that we use is mainly by the osmotic gradient. They help in removing the excess water. They reduce the ICP, and also by this they help in reducing the tension and improve the cerebral perfusion pressure. So the various agents available are hypertonic saline, mannitol, and dexamethasone. Dexamethasone is very ill-sustained, has shown to have very ill-sustained reduction in ICP when compared with mannitol. This is one of the studies done by Hausen et al. In 2018 in neonates with raised ICP secondary to HIE. He had studied 60 neonates, and it is just an observational study. And there he concluded that dexamethasone, though it reduces, but the response is very ill-sustained. Now, there has been a meta-analysis which has come out where they have compared hypertonic saline versus mannitol. This is involving 17 RCTs in pediatric age group. And what they have found is hypertonic saline definitely reduces treatment failure and reduces intracranial tension, and also increases the cerebral perfusion pressure, which can last almost for 30 to 60 minutes. But this effect is not long lasting when they did the same measurements at 90 to 120 minutes. And the significance or difference between the two agents is not obvious for mortality or the final outcome. And they have not done any long-term follow-up studies of the same. So we don't know how good is each one of them when it comes to neonates, when it is not clear in pediatric age group at all. Coming to hypertonic saline, there was an observational study which was done by Konak et al. In 2019, where he studied neonates with hypertonic saline and mannitol was used. And what was seen was hypertonic saline was associated with better ICP reduction, but the difference became insignificant after adjusting to various other parameters. However, when they had done seen what was the etiology amongst each, for vasogenic edema, especially when there is meningitis, encephalitis, and cerebral ischemia, hypertonic saline seemed to be less sufficient, and mannitol was seen to be more preferred. But overall, hypertonic saline is safer and is the preferred initial modality of choice, definitely. And in acute conditions, 3 to 5 ml per kg and continuous infusion of 0.5 to 1 ml per hour would be preferable. Coming to mannitol, it is definitely preferred when there is impending herniation or there is acute deterioration, especially as I mentioned before, when their causes are predominantly secondary to vasogenic edema. So the dose is generally between 2 to 5 ml per kg over 20 to 30 minutes. Always mannitol is given as bolus and never as continuous infusion. The main problems with mannitol are it suddenly increases the serum osmolality. So always when we are giving mannitol, we should ensure the overall serum osmolality is less than 320 milliosmoles per liter, and serum electrolytes and renal functions should also be monitored frequently. The known side effects of mannitol are hyperosmolarity, hypovolemia, electrolyte imbalance, and it can also cause acute renal failure. When there is refractory ICP and you know that there are treatable causes, then the main area can be CSF drainage or decompression craniotomy or treating the underlying cause. So this is all. CSF drainage can definitely be done if there is a hydrocephalus where it has shown to actually reduce the ICP and help giving us the bite time and prevent herniation. But decompression craniotomy and all has not been seen or done in neonates as of now. So coming to the key points of my seminar, brain herniation, though uncommon, can definitely happen in neonates. Clinical suspicion and neurological examination at the time of admission and at frequent intervals is definitely a must. And consider mannitol when suspecting impending herniation along with 3% NaCl, which is actually the first modality of choice. And CT scan is a quick and good modality of choice for detecting herniation. And as always, we know prevention is always better than cure. So we should try to act faster and always suspect when there is all the case scenario is actually suggesting that the baby might at any point of time may go for raised ICP or impending herniation. So thank you.
Thank you, Anjali. I think people would have got a gist of brain herniation. We saw I would like to thank Dr. Sunita, our neuroradiologist, also, who helped Anjali and I with this presentation, with all the images, and she actually helped us in diagnosing this baby as well. So let's take any questions. One first question was EEG was done. I think it has been answered. We could do amplitude integrated EEG, but baby was very sick, so conventional EEG was not done, and it was showing burst suppression. And to Sanju, if you're there, can you elaborate on the baby that you saw? Yes, you can unmute and talk. Okay, it seems Sanju also has seen a case similar. We have seen, I think, at least 3-4 with one was following hypernatremic dehydration correction. One is this HIE, another 2-3 followed by intracranial bleeds, following intracranial bleeds. So it's not that uncommon, but it is very underdiagnosed. So I think imaging is the modality of choice, and whenever we find some neurological examination which is unexplained, I think we should definitely think of an acutely deteriorating baby with an unexplained extended posture or pupils which are dilated and fixed, unequal pupils. Then we should definitely get an imaging done, and most of the time it can show herniation. So we have another question, two questions really. Was there SIADH? Do we need to treat with 3% NaCl, which helps in SIADH also? Anjali?
Yeah, so this baby actually did not have hyponatremia per se to begin with. Initial sodium were around 132. Later on, definitely it had around 126. So we had considered SIADH even before considering this raised ICP. Like though we felt on clinical examination there was raised ICP, we had started this baby on 3% NaCl correction even before that. But it was not going in it was just as a part of SIADH or for hyponatremia correction. But we did not start at this rate where we should actually give it at 0.5 to 1 ml per hour. So this is the thing I would like to say. So we changed it to a higher dose once we got this diagnosis that there is already an impending herniation at that point of time.
Okay, how long can we give 3% NaCl?
It all depends upon the clinical condition, I would say. If at all, if it also depends upon the degree of herniation also. So as I said earlier, if it is irreversible, then it is irreversible. So even if you give 3% NaCl as long as it's possible, the advantages of 3% NaCl is it will definitely help in reducing the ICP and also improves, but it cannot reverse the herniation if it is already very severe. So you can consider continuing 3% NaCl infusion, but we will have to monitor other things like the fluid status and also the sodium levels and also the urine output. I think these things which we regularly monitor should be continued to monitor.
Yes, I think we hardly we give mail maybe for 24 to 48 hours.
Yeah.
After that, it usually doesn't work. So I don't see any more questions. In that case, I think we can close this session. So thank you, Anjali. Thank you, everybody, for joining on first session of 2023, and hope you gained something from this session. Thank you.
Thank
We'll
you,
close.
sir. Thank you, sir. I'll close, sir.